I'll stand.
Thank you all so much for coming. My name is Amanda. I'm from Drive Counseling Center. I'm really happy to have you all here with us. Tonight's topic will be closing the gaps, and you'll hear from two of Thrive's engagement specialists, Emily Dahl and Jason Allington. I'll let them further introduce themselves, but thank you all so much for coming. At the end, I'll just ask you all if you could just complete a survey. Just kind of helps us get some feedback of what other topics you'd like to see. At the end, they'll answer any questions that you may have as well. And again, thank you so much for being here.
Thank you all for coming out tonight. This is going to be a lot of fun. I hope you all walk away with some good learning and maybe a little more enthusiasm about the peer support movement and the promise that it holds. The subject of our talk is the power of peer support in mental health recovery, closing the gaps. As I mentioned, my name is Jason and
Emily Dahl.
And we're just going to jump right into it. We're going to break in a few slides. We'll tell you a little bit more about ourselves, but we thought we'd set the table first and get into the subject right away.
Absolutely.
So our agenda, what we hope to do today is help you understand why peer support matters. Why are we having this conversation? What is peer support? What is it? What is the definition? And then give you a little bit of history and some of the methodology behind peer support, what's made it successful and where it comes from. Then finally, we'll look at the impact it's having in the real world, locally and nationally, and talk about some of the future hopes that we hold for the peer support movement. So starting with why does it matter? Why are we having this conversation? 1 in 5 adults, many of you might know this already, 1 in 5 adults have a mental health disorder of some kind, a diagnosed mental illness in the United States. Millions of these people face enormous barriers and stigma in getting care. They get fragmented care and sometimes lack connection. We have a problem of isolation in the country as well that's contributing to this. Ever since COVID, it's just gotten worse. And then traditional services, psychiatrists, psychologists, medical doctors often miss the human and lived experience element of recovery. And that is a gap that we fill in the peer support arena. The cost of this, these stakes at hand here, are of inaction. The cost of not doing something to address these issues is enormous continued human suffering and a lot of money. A lot of money. $477 billion, $500 billion a year currently in avoidable costs due to mental health inequities. All right, $1 trillion a year lost to productivity in the world from depression and anxiety, and expected $14 trillion by 2040. Some of these things, some of the underlying numbers behind this are over here. Emergency room care. It is unideal at best to go to an emergency room with a mental health crisis, but that's still the main place people end up going in a mental health crisis. Incarceration. We'll get into this in a bit, but incarceration has taken the place of mental health facilities for a number of, a large portion of the population. There's medical comorbidities. Mental illness is also physical illness, so someone with a mental ailment often has symptoms, physical symptoms that go along with it that cost money, and then lost productivity we talked about as well. Our inability to satisfy this need creates numbers that are almost impossible to understand, right? These numbers are ridiculous. They're huge. They're abstract. So let's not worry so much about the numbers, but I want you to look at those numbers and understand that these figures, behind every one of those figures, are millions of people not getting basic mental health care in the community. Which brings us to the subject of today, peer support. Where does peer support come in? And I'm going to start by telling you a story. Story time. So, a guy falls down a deep, dark well. He's hurt, injured, he's scared, and he's yelling up for help. A person walks by the well and looks down and says, "I'm sorry this happened to you." And he throws down some brochures and walks away. A second person comes along, looks down the well, and says, "You know what? You should have been more careful and not walked so close to the edge." And he walks away. A third person comes up and they look down into the well and they pause. And after a moment, this person swings a leg over the edge of the well and climbs on down to join the person at the bottom of the well. The person at the bottom of the well says, "What are you doing? Now we're both trapped down here." And the peer says, "Yeah, but I've been here before. I know how dark it gets, and I know the way out. You don't have to do this alone." That's peer support. not judging how somebody fell, how they ended up there, not rescuing them from above, not fixing them, but choosing to sit with somebody at that moment when they're in their hardest place because you've been there before and you can never get out. That's what peer support's all about, is the basic crux of it. Now just a quick little bit about Emily and myself. I'll start and then we'll go to Emily. My name is Jason Allington. I live in Oak Park. I've been in the peer support world since 2008. I started as a consumer of peer support services myself. And in that time, in that 18 years, I have become a peer support leader in group therapy. I've spoken in hospitals, I've spoken to police departments, I've been on the board of directors of the local NAMI chapter here. I have spoken at hospitals numerous times, giving hope to patients while they're still in hospital. 3 years ago, I had the good fortune to be laid off from a job. My previous career, which is in sales, and I had the opportunity to move careers over to the mental health field. And I've never been more satisfied with the work that I do in this field right now. In addition to working for Thrive, I also work for NAMI Metro Suburban. I am in charge of a grant, a state grant that we've been working on for the last year and a half. I lead a team of certified recovery support specialists. These are certified peer specialists, peer supporters, who work with patients at Madden State Psychiatric Hospital. Madden Hospital, for those of you who don't know, is a safety net hospital in the suburbs. It is where people who are uninsured go. Lots of folks that are unhoused, lots of folks that are undocumented, really the most desperately in need people in the mental health community. My team works with these individuals after discharge. We get to know them when they're in the hospital, and then after they leave, we spend up to 6 months working with them on a week-by-week basis as peer supporters, helping them in their recovery to have a successful recovery. So far, we've helped, in a year and a half, we've helped 160 people we brought through the program, and we've seen the readmission rate for our group is about a third of what it was before we started. It's about 7% was our readmission rate, which is quite low. We have seen peer support work. So that's where I am today. Now I'll pass over to Emily.
So my name is Emily. I'm here today because my first peer supporter, my grandmother, survived a suicide attempt when my dad was 13 years old. That had a really big impact on him, on our family, and she was my first peer supporter. She was one of the reasons that I trusted going into treatment. So for about the last decade, I've lived with bipolar disorder and post-traumatic stress disorder. And in August of 2023, I had a particularly catastrophic episode that just threw my entire life into upheaval. But it actually turned out to be probably one of the most serendipitous things that ever happened to me, because I got connected to the incredible peers at the NAMI Drop-In Center here in Oak Park. So that included Sean O'Connor, Jason here, Lisa Donnelly. They took me in as the most broken version of myself, supported me, listened to me, empathized with me, and helped me believe in myself again. So I started off doing the CRSS core courses at the College of DuPage. And then in the spring of 2024, I joined Thrive's mobile crisis team as an engagement specialist. And then I'm also a CRSS intern at the Drop-In Center as well. So, and stroke of serendipity and peers who believed in me are the reason that I'm able to be here in front of you guys today. Alrighty, so when we are talking about recovery, we're talking about a process of change. So a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. That's according to the Substance Abuse and Mental Health Services Administration, so what many of us are used to calling as SAMHSA. So when we are looking to support a person, when we're talking about this holistically, we're looking at several dimensions where we're implementing these 10 guiding principles of recovery. The most cardinal and most important one is hope. We're here to provide hope. It's relational and it's non-hierarchical. It's person-driven. It's culturally competent, culturally aware. We respect that individuals are experts in their own life story. We acknowledge that recovery occurs via many pathways, so it's non-prescriptive. What works for one person may not work for another. And the thing that I always like to acknowledge is that not everybody has the same soil and the same sunlight to grow in. And so if we're going to help people thrive, we need to acknowledge that lack of access to resources, lack of social supports, those have a big impact on people's ability to access recovery. It addresses trauma. Trauma-informed practices are incredibly important in peer support and how we help empower individuals. It's holistic. So again, when we're looking at these 4 dimensions, we're looking at health. So we're looking at overcoming or managing disease and living in a physically and emotionally healthy way. When we're looking at home, having a stable place to live, housing is recovery. And purpose, conducting meaningful daily activities, having independence, income, and resources. And then probably one of the most important facets of this is community. So it's building relationships and social networks that provide support. And in this practice, we look at strengths and responsibility. So we look at not at what's wrong with people, but what is strong, what gives them their resilience. And then respect. Again, we treat people as experts in their own lives. And we respect that we're meeting them where they're at, wherever that stage of change is. We respect where they are in that part of their journey.
So as peer specialists, Emily mentioned that she went to the College of DuPage to get her certificate as a certified recovery sports specialist. I did as well. Now that peer specialists have an official designation, they've also got a very specific set of principles that they live by here. Peer support's always voluntary. We only help people that are ready to be helped and want to be helped. We're hopeful, open-minded, we're empathetic and respectful. Emily mentioned that before. We help facilitate positive change. We're always honest and direct. The engagement is mutual and reciprocal. Power is shared equally. It's non-hierarchical. We're not talking down to people. We're on the same level as them. We focus on strengths. We're transparent and person-driven, as we mentioned before. Anyone who's worked in recovery or worked with people in recovery will recognize some of these principles. There's a through line in the recovery movement that looks a lot like this. On a personal note, I mentioned that I lead a team of peer support specialists at Madden Hospital. We call them CRSSs again. One of the requirements of being a certified recovery support specialist is having a lived experience yourself with the mental illness. And what makes that interesting is that for most people who are living with a mental illness, especially an acute mental illness, their illness is an enormous barrier to employment. It is really hard to get work, even now as employment numbers are getting bad, it's even worse. But for my team, for CRSSs, not only is mental illness not a deterrent to employment, it's a requirement. It's a requirement and it is seen as a strength. I won't hire somebody who hasn't been in the hospital, right? How wild is that? How wild is that? We're in a time right now where you cannot work for me if you haven't been in a psychiatric hospital. I think it's amazing. How does this all look in the real world? Empowerment through experience. Absolutely. This is, I like this picture because it really shows what it looks like. This is what peer support looks like. It's 2 people talking. Empowerment grows out of the relationship between a peer supporter and the person that they're helping. Right? When they work together, recovery shifts from being something prescribed to being something personally owned. Shared lived experience builds trust in a powerful way. I'll tell you, when I see my team in the hospital, in the pavilions of Madden Hospital, when they say to a patient, "Hi, I'm not a doctor, I'm just somebody who's been where you are and wants to help," you can see their defensiveness lift. You can see them smile, you can see them open up, you can see them realize, oh, wait a minute, this person might be helpful. It happens darn near every single time. It's an enormous breath of fresh air for people who are introduced to peer support when they're in crisis. And it's very empowering to see it. When someone can say, I've been there too, it helps people feel understood and less alone, which further builds confidence. People start asking questions, they start speaking up and taking an active part in their own recovery. Research shows that this kind of empowerment leads to better self-management, fewer hospitalizations, which is one of my favorite things about this, improved quality of life, and most importantly, people begin to believe in themselves again. And I'm going to pause right now and go to Emily, who's going to give us a little bit of history of the peer support movement.
So, I think this image is really, really powerful when we're thinking about the early foundations of the peer support movement. So, in the late 1700s, we saw the rise of the humane care or the moral treatment movement. Philippe Pinel is known as the father of psychiatry, but he was actually preceded by Jean-Baptiste Poussin and his work in humanizing asylums. So his main strategy was hiring recovered patients as staff. So when we're looking at this photo here, the title of this painting, so this was painted in 1795 by Robert Fleury. This is called Removing the Chains. So you can see the women here that are sitting on the ground. They're chained to the wall, the pipes, chains are attached to the pipes here. Poussin is actually the one here removing them. And then we have Pinel here observing. But I'd like to take a look at this gentleman here with the apron. That is probably the first artistic depiction that we ever have of a peer support worker. So Poussin's approach at this time was pioneering. And this was at a time when conditions in these institutions were abhorrent. When we think of Bedlam, this was worse. So as we can see, people were caged to walls, they were beaten, they were isolated, they were starved. And what Poussin saw was the power in treating people with dignity and with respect. And then Pinel advocated for the effectiveness of Poussin's practices in this really critical reform period. But this piece was really, really moving to me. So when we are talking about peer support, we're not talking about a trend. We're not talking about a new workforce initiative. We're talking about a movement that was driven by people, and it's been unfolding over the last 2 centuries. And it's been led by people with lived experience who refused to accept the inhumane treatment, and they demanded dignity, voice, and humanity in care. So from the moral treatment movements at the beginnings, to civil rights activists, to modern certified peer specialists, this has always been about one core belief. And that's that the people that are closest to the pain are closest to the solutions. And again, I think it's really important that we humanize that all of these people here suffered and they turned around and wanted to pay it forward and make it better for others. So starting with the moral treatment movement, bringing it to the United States, we have Dorothea Dix. So she exposed the inhumane treatment of people with mental illness in the 19th century and successfully pushed for the creation of more humane state hospitals that were grounded in moral treatment. She herself actually suffered with depression and several bouts of psychosis, but because during her time convalescing in Europe, she was treated well, she was treated with care and empathy and respect, she realized that people deserved so much better than what we were providing at the time. And then, of course, we have to talk about Harriet Tubman. So, despite living with seizures, with narcolepsy and visions after surviving a traumatic brain injury, Harriet Tubman led countless enslaved people to freedom, and she embodies the power of resilience and lived experience. She was the most effective conductor of the Underground Railroad. Clifford Beers. So as we're moving into the early 1900s, after surviving abuse in psychiatric hospital, Clifford Beers sparked the mental hygiene movement by publicly exposing mistreatment and advocating for prevention, education, and dignified care. And then getting a little bit further into the 1920s, we have Harry Stack Sullivan. So he also experienced episodes of psychosis. And despite that, he advanced interpersonal psychiatry, and he also demonstrated that people with serious mental illness are fundamentally human and capable of recovery. Because for a long time, when we looked at mental illness, it was seen as a character flaw, demonic possession. These people were beyond saving. Harry Stack Sullivan also followed Poussine's example, establishing one of the first inpatient treatment centers for psychosis in Baltimore, and he brought in recovering patients to serve people that were in that facility. And then, of course, if we're talking about peer support, we have to talk about Bill W., Dr. Bob, and as the co-founders of AAA. So in 1935, Bill W. and the founders of Alcoholics Anonymous formalized mutual aid, proving that people in recovery could effectively support one another outside of traditional medical systems. Dr. Ildara Murillo wrote, so we're moving forward into the 1970s, we're looking at the deinstitutionalization shift, ex-patient movements, continuation of the civil rights movements. Dr. Ildara Murillo wrote Advanced Culturally Competent Psychiatric Care and founded the National Association of Hispanic Nurses to address disparities in representation and treatment. She also served with the WHO as an advisor to Guatemala for psychiatric care, and she was also a representative from the UN serving for UNICEF. So pretty pioneering for her time. And then, of course, we have to mention Audre Lorde. So Audre Lorde transformed her lived experience into poetry and activism that shaped intersectional advocacy and challenged systems of oppression in mental health and beyond. So she described herself as warrior, poet, Black woman, lesbian. She actually founded one of the first publishing companies for African American women here in the United States in 1981. So when we're looking at the evolution of peer roles, what started as informal and unpaid, research eventually validated their impact over time. So first, studies showed, as we're looking at the expansion of the workforce in the late 1980s, 1990s, the research validated that it was actually feasible to hire people in recovery. As we move forward in time, research showed that peers achieved outcomes equal to or better than traditional staff. And then as we move along more into actual formalization, training, certifications, integration, now the research is actually looking into peers' unique contributions into fostering hope, engagement, and recovery. A lot of our research for this presentation was from Dr. Larry Davidson, and he noted that life-based evidence has driven especially meaningful policy change, and it continues to do so. And then, of course, we have to talk about our homegrown heroes. So as mobile crisis responders, we're often working alongside police and emergency medical services. So we have to talk about Peter Safar and the Freedom House Ambulance Service. So established in 1967, Dr. Safar helped develop the first 300-hour paramedic curriculum and co-invented CPR alongside Dr. James Elam. But it was the Black men and women of Freedom House Ambulance Service in the Hills District of Pittsburgh who operationalized ALS, advanced life-saving skills, in the field, and they set the national standard for that mode of care. And then next we had Fred Hampton and the Rainbow Coalition. So at only 20 years old, he became the chairman of the Illinois chapter of the Black Panthers, and he recognized how poverty and systems of oppression impacted well-being. And so in founding the Rainbow Coalition, he united people across racial divides, across gang ties, and brought them together to establish medical clinics, free lunch programs for young children. They worked for fighting against police brutality, and also in housing advocacy as well, among many other things. I apologize, my notes here. And then as we look into the ex-patient movement, Jenny Fulgham, so in the late 1970s, she was a survivor and she founded the first crisis respite, so the Zuni Federation for Mental Health. Moving along, we have the National Alliance on Mental Illness. So that started as a grassroots movement, and that was founded by family members that wanted to advocate for education and better treatment, because they saw the need for, just from watching what their family members were going through in their own treatment. When we think about the deinstitutionalization shift in the 1970s and the 1980s, we see what's called the seesaw effect. And so as people were moved out of institutions, we saw a sharp rise in incarceration rates that continues to grow to this day. So I have a question. Take a guess. Feel free to raise your hand. What do you think is the largest treatment institution for mental health in this country today? Go ahead. In the state, yes, but in the country, it is the Los Angeles County Jail. So Peter Wagner, when he founded the Prison Policy Initiative in 2001, their research is looking at disparities in care. It's looking at how mass incarceration, over-policing impacts community mental health. We're looking at, they've similar to PTSD, they're looking at a syndrome called post-incarceration syndrome. And so what they're looking at is how barriers to care, lack of funding, lack of resources, impacts how people are engaging with these systems and often end up in incarceration and being re-traumatized, rather than getting the treatment that they need, being punished for having a mental health or a substance use condition. And then we have DeWitt Buckingham. He's the co-founder of Black Men Speak, so that was 2009. And then one of my favorite figures, Ellen Sachs, she lives with schizophrenia, and her experiences with psychosis and forced restraint during inpatient treatment pushed her to advocate for ethical practices, again, in forced restraint, ethical practices in psychiatric research, and she's one of the, she was actually one of the advocates that I resonate with the most. I learned about her in my own treatment. Okay, and moving back to Jason.
Thank you for that history. It's amazing to me. I didn't know all this stuff until Emily did this research and brought this to my attention. Really incredible. I think of peer support as being a new thing, right? But it's been around for more than 200 years. It's extraordinary. Anyway, how does peer support work? The nuts and bolts. Starting with normalizing experiences. What peer support does is it helps individuals see their challenges as common. I'm not the only one living with this. Other people have been through this before. I'm not alone. This reduces shame. It also reduces stigma. Peer support focuses on safe spaces. This is something that from NAMI I have a lot of experience with through the Drop-In Center, which is at its core a safe space. These are judgment-free environments that foster openness for honest sharing without fear. And then finally, community connection. Isolation is the enemy of recovery. Community connection is the cure. And regular group interactions will build belonging and combat isolation and loneliness, which is afflicting us all. And the empirical impact of this, peer groups increase social inclusion and service use, so they are more engaged in their own recovery, and therefore they have better results in recovery because they are more engaged. So it feeds itself. Along. So, building trust and fostering hope. Peer support action. A couple numbers for you. I'm not going to test you on this. 72% of participants who have had peer support report higher hope and trust, which improves recovery outcomes. Shared lived experience builds trust, authentic stories foster hope, and reduce fear of skepticism. 38% reduction in depression symptoms of people with experiencing peer support versus a control group. So this has been studied in a controlled setting. And then we see a 42% reduction in hospital readmissions when peer support is introduced to the recovery process. This ties in almost directly with what I'm doing with my team. The core pieces of the puzzle in providing this care, the strength-based approach we've talked about, it's not what's wrong with you, it's what's right with you. What are your strengths? What do you have to work with? What's in your toolbox? Changing the lexicon, person-first language. I think we've all experienced this. We all know what this is about. We no longer say Joan is schizophrenic. We can say she is a person who lives with schizophrenia or manages schizophrenia. I remember when this first started happening a few years ago, I was very skeptical, but it is so obvious to me now. I see how it impacts people to be, the person-first language really does matter. It changes changes the dialogue and changes the relationship that we have with patients and people in recovery. We recognize stages of change. Not everybody is in the same place. Some people aren't ready for change. Some people are frustrated with change not working. Some people are ready to drop out entirely. We meet people where they're at. In fact, we recognize relapse as part of the process. Relapse is recognized as an integral part of recovery and an opportunity to learn and grow. Peer support reduces isolation, which we mentioned before, and stigma. The non-hierarchical partnerships, again, some of this stuff is a little bit redundant, but there are some points that I think are so important they're worth repeating. The fact that these are two people side by side, this is not a doctor and a patient, these are two people side by side working together for the benefit of one. Let's see, move along. Back to you.
So this was something really, really exciting that I first learned about during our curriculum at the College of DuPage. So as certified recovery support specialists, we actually have our own code of ethics that we're required to adhere to. And our training at the College of DuPage included formal coursework in ethics and systems thinking. So Yuri Bronfenbrenner was a developmental psychologist that first introduced the ecological systems theory in the late 1970s. And what I think is really important about this model is that it reminds us that recovery does not happen in isolation. Recovery is not happening in a vacuum. So individuals are shaped by these interconnected systems. So family, community, institutions, policy changes over time, whether that's in culture, politics, economics. So as peers, we're not just supporting that person, but we're also walking with them. We're helping them navigate and influence the systems around them. But what's really cool is that these influences are bi-directional. So what that means is change in one area can impact another. And so if we're empowering people for positive change, this gets me really excited, because think about the way that can ripple outward and create broader positive systemic impact. People like Ellen Sachs, people like all the people that we just discussed. When we're looking at the history of this, this is a person-driven movement. Alrighty, and then we're looking at where peers are already embedded. So the VA has been using peers since the early 2000s in like the formal sense. There was a big hiring push in the early 2000s. And then we've got Jason's team at Madden, but we've got Thrive's mobile crisis response model. So the grant that we operate under requires engagement specialists to be part of the crisis response teams. So we're doing kind of that front end response when things are going wrong, but Thrive is also trying to take a preventative upstream approach. So one of the things that we do is we actually facilitate QPR. So we facilitate suicide prevention trainings, and those are often facilitated by peers, and then our crisis workers too often help with that as well. But again, we've got peers embedded into housing and homelessness services. They're utilized in substance use treatment and crisis respite programs. And then the living rooms. So what is a living room? A living room serves as an alternative option to the emergency room. So here a person that's in acute distress can talk to a peer who's there to provide empathy, they're there to provide resources. If the peer wants and needs it, we can work on problem solving, work on safety planning. But they also do keep clinicians on staff who help with risk assessment as well. So if we need to coordinate for a higher level of care, inpatient hospitalization, we always try to treat that as a last resort. We use a model that is the least restrictive means of support, so we really want to try to keep people within the community. But the living room was not something I learned about until literally when I started working in this field. This was something that I wish I was aware of, especially when I first started engaging with treatment. So that was back in like 2015. This is something that I feel like I would have made a huge impact, and maybe it wouldn't have taken a decade to get this far. But yeah.
Which brings us to my home base here. Community drop-in centers, like NAMI's Metro Suburban Drop-in Center. Has anybody been to the drop-in center here in Oak Park? Terrific. Okay, you know what we're talking about here. They not only provide opportunities for connection and immediate peer support, but they also offer a variety of free, supportive, educational programs. These programs include NAMI Connections and daily support groups. NAMI Connections is a once-a-week, 90-minute support group, open support group. That was my first introduction to peer support as a consumer and was instrumental in helping me with my own recovery journey. We offer Wellness Recovery Action Planning, or WRAP. This is a 6 to 8 week course. It's free. People can show up and literally work on a workbook of how to manage your own mental health. It's what to do if this, what to do if that. It's an incredible program. It's been very, very effective for hundreds of people who have gone through it. We also offer family-to-family classes, which are educational programs for people who want to learn how to better help their loved ones. If they had a child or a spouse or a partner who is living with mental illness, and they just want to understand the illness, and they want to understand what can I do to support this loved one. And then we also have a robust youth program, NAMI, and going back to the living rooms piece, this is hot off the presses. Next month, half of this building is going to be dedicated, half of this office is going to be dedicated as a living room. It's been open from 12 till 8, Monday through Friday, and then a little bit more limited on the weekends. It is a locally funded program to introduce the living room model to the Oak Park area. What's nice about that is the drop-in center is a perfect place for somebody who is in recovery and working their program. They're doing okay, but they just want a place to hang out, where they won't be judged, where they can participate in activities and talk to people and hang out. Sometimes people come to the drop-in center and their acuity is a little higher. They're a little more in crisis than is appropriate, that we can really help them with at the drop-in center. Historically, when somebody comes into the drop-in center in that state, we have to send them, put them in an Uber and send them to somewhere else. Now we can have them walk right next door and get paired up immediately with a peer support specialist who can help them de-escalate and get to a safe place in their own mind. I'm so excited about this. I can hardly talk about it. I've been working in this field since 2008, and we've been wanting a living room in Oak Park since about then. This is great. About my history, so I mentioned 18 years I've been working in this particular facility. I have seen, in my time there and in my time working at Manton, I have seen more miracles than I can count. They're not the loud, dramatic kind of miracles, they're quiet ones. The kind where someone who once felt hopeless now gives hope to others by her own example. The kind where a person chooses to try one more time. And the kind where trust is rebuilt, one honest conversation at a time. These are the miracles I see on a daily basis. But don't take my word for it.
Yeah. Before we move along, too, I want to make sure we mention in terms of youth programs. I want to make sure you guys are aware too that in terms of youth mental health, we also have, based out of Brookfield, NAMI's Loft at 8 Corners. So I always try to talk about this when we're doing QPR over at the high school. So when we were at OPRF, when we're at Trinity, but the Loft at 8 Corners, based in Brookfield, is a partnership between Pillars and NAMI. So they're for supporting teen mental health. So I believe it's 6th to 12th grade, and they kind of separate based on the age groups, but they do have youth-geared peer supporters, but it's and activities groups, very, very similar to the drop-in center model, but they also have parent support groups too. So they offer one that's in person, they offer one that's virtual. So if you know anybody that has a teen, whether it's middle school, high school, that is struggling with their mental health, this can be a really nice way to dip their feet into getting support in that group setting and help them become more comfortable kind of engaging and talking about mental health. And then the family support specialists are there also to kind of help navigate, okay, this is going on, you know, what kind of insurance do we have? What kind of treatment facilities do we have options for if things escalate and that community-based support isn't enough? And so that's a really important resource, I think, when we're talking about our teens. But yeah, as we're moving into looking at actual testimonies, I think these are really, really important, you know, in humanizing what this experience looks like. One of my favorite ones here is that peer support helped me realize that I have inherent value and worth, and it's not contingent on what I produce or who I am. And then this one actually rings true for me. After 5 hospitalizations, I really wish I had found NAMI sooner. Peer support kept me from being hospitalized by supporting me in building support systems that I could turn to whenever I experience a crisis. So when we discuss peer support in any dimension, we have to move beyond looking at data. Peer support is about people, it's not about numbers. All right, and then again, referencing, I can't talk about Dr. Larry Davidson enough. A lot of our material from this presentation is from his webinar. So the National Association of Peers has their own YouTube channel, and the history of the peer support movement was where we pulled a lot of our information from. But this was something that really, really stood out to me, and I think this shows what we're trying to do. So we don't want to see peers hired into systems which are then going to use them to continue the same coercive practices that were there before we were introduced. We're here to transform these systems. We're here to humanize them. We're here to make them better for the people that we serve. All right, and then when we're looking at where else can we see peer support being implemented, schools, community centers, and support for the elderly, businesses. And the research right now is really underscoring the need for clear policies, supervision frameworks, and sustainable models to realize benefits while mitigating some constraints. So when we're talking about implementing peer support, what kind of questions do we need to be asking? How do we protect peers from compassion fatigue and burnout? How do we ensure that peers have adequate supervision, mentorship, and leadership opportunities? How do we protect peers from discrimination in their roles? I think this is also really, really important right now. How do we help bilingual peers overcome systemic barriers? Whether it's in therapy, traditional therapy, or in peer support, we are in desperate need of bilingual providers, because again, it's human, it's relational, and so when you're talking to somebody, that language element there is really, really important. And then how do we protect and expand funding for programs and training? That's where CEU, continuing education. Right now, I'm taking part in the CRSS competency training. So they have these annual trainings that we can do that help us better understand how to implement our code of ethics. And what's great is that's through IDHS, so it's free. So again, back to Larry Davidson, the hope is that peers will have a transformative effect on system agencies and systems of care to make them more responsive to the needs of the people that we serve. And talking about, again, one of the most critical elements when we're talking about peer support is trust. So a lot of us peers have trauma specific to engaging with the medical system. So this not only has critical implications for the people that we're serving, but also for our own exposure to vicarious trauma and burnout. But again, going back to the competency training, the competency training from last year in 2025, it introduced us to something that I'd never heard of before. So we were looking at how do we transform vicarious trauma into vicarious resilience. And I think that's actually one of the most rewarding things about the work that we do. So vicarious resilience is where we build strength, we build resilience, and we overcome burnout by watching the peers around us recover. We watch them become more empowered. We watch them become more autonomous. They speak up, they advocate for themselves. And I think that's what helps push us and keep us in the field. And then this is something I'm especially passionate about, is so how are we embedding peers into crisis response and also into the justice system, into the legal system. So the sequential intercept model here is a framework that helps us to see opportunities to coordinate and help funnel people into medical care and into community-based supports rather into systems that are going to re-traumatize them. So again, we're already embedding peers into crisis response, but I think one of the biggest areas of growth that we can see is embedding peers into diversion courts. For quite a while now, we've had diversion courts for veterans, but even here in Cook County, we have mental health court diversion programs that help people. They provide wraparound services to people, and those that graduate actually have their records expunged. So that's opening up more opportunities for housing, for employment. And so where I think we can see a lot of growth is if we embed peers into these diversion courts, we can transform these systems that are very much punitive, they're paternalistic, and we can turn the measures that they're currently using and shift them into strengths-based and person-centered and, most importantly, trauma-informed practices that are actually going to foster people's recovery and support their autonomy.
And to bring it all home, the question you're all asking yourselves, how can me, be a peer supporter? I'm going to tell you right now. We mentioned the Illinois Department of Human Services. In December of 2021, they launched something called the Success Grant, which is a well-funded program that makes it a free ride for anybody who wants to be a peer supporter and get certified. This grant that makes you a recovery support specialist covers tuition, books, all the certifications you might need, the Illinois Certification Board, technology, stipends for internships. You actually get paid while you're interning, you name it. They support all the core functions and help teach the core functions. And these are a list of some of the schools that are offering the programs right now. When Emily and I have both been through the program at the College of DuPage, it's only a year long, and there's a 300-hour internship tacked on to the end of it, and after you take a test, you are certified to be a recovery support specialist. When this was introduced, it wasn't just new funding for a program, it was a statement. It said to the public that lived experience matters and that recovery belongs in our communities, including on our college campuses. Through this grant year, peer support specialists have been trained, certified, and integrated into real systems of care, including the ones that Emily and I operate under currently. These people are not volunteers sitting on the sidelines. These are skilled professionals trained in communication, crisis response, ethics, boundaries, providing advocacy and education, and navigating through systems that can otherwise feel overwhelming. This is a soup to nuts wraparound educational opportunity that is free for anybody who wants to get into the program. Quick side story. Amongst the 160 people I mentioned that my program has helped in recovery, individuals, 3 of them have said to myself and to my teammates, how do I do what you do? How do I be? This is somebody who we got out of Madden Psychiatric Hospital at the worst point in their life. And with a little bit of peer support, and a little bit of encouragement, they turned around and said, wait a minute, I want to do what you're doing. I like what I'm seeing and I want to do it. We've got 3 people currently enrolled in these programs that were United States that had hospital patients a year to a year and a half ago. I'm super proud of that, and I'm super excited about the potential that really brings. So here's my hope. I hope that you leave here seeing that peer support is not an extra, but an essential, cost-effective, and immediate response to the mental health crisis that's facing our country right now. The gap in mental health. And more than that, that you can see your own role in this process and helping it grow. Because as we've already pointed out, the need for this kind of support is enormous. And the solution, it's already working. So with that, I welcome questions from the crowd. Yes, sir?
Obviously, to me, your work has got to be very, very intense, probably much more intense than a normal mental health person. And you touched on it a little bit. What kind of self-care is built? I understand it's in your system.
Yeah.
What about outside your system of giving self-care for the people in your team?
Mm-hmm. Tremendous. Self-care is something, specifically with my team, I have every quarter, we have somebody come in and do like a seminar on self-care, but on a more specific level, I encourage everybody on my team to allocate a certain amount of time every day, usually end of day, to self-care. I want there to be a distinct unwinding period from when they're engaging with patients and then going home. That's very important. Self-care is probably the thing I worry about most, so I'm glad you brought that up. It's exceptionally important. Emily mentioned the idea of vicarious trauma and vicarious resilience. That's what that's about. Vicarious trauma is very real. I have felt that before. Working for Thrive, I have gone on calls that have been quite traumatic and quite upsetting. But I've taken great comfort in knowing that I was able, and I take it as an honor, actually, to be able to be injected in these situations where people are in real crisis. Help them get level, help them get where they're no longer in crisis, and get them to the next place of care. That makes me feel so good. That's vicarious resilience. It's seeing these things happen. I mentioned miracles earlier. I don't go a week without seeing a miracle, either at NAMI or at Thrive. Not a week goes by. I don't see somebody doing something magnificent who sometime in the past was sitting in a corner weeping. Seriously. It happens all the time, and it's incredibly rewarding. I spent 30 years in a career before I came here. I spent 30 years in the advertising sales world, internet advertising, 30 years. Made a great living, but I had no sense of satisfaction from the work I was doing. There was absolutely no reward for it apart from money. I've come over to this, and I've never felt more reward in any job I've ever had. So vicarious resilience can be had, and thank you for that question.
And I'd like to speak to that a little bit as well. So what's really cool, especially about the internship program at the drop-in center, is there's a lot of freedom for what we can do in terms of what type of groups we want to facilitate. So like for me, with especially post-traumatic stress disorder, one of the most powerful tools that really, really helped me was yoga. And the drop-in center gave me the freedom to facilitate my own yoga group, and that in and of itself has been really, really rewarding because we work together to create our own group guidelines. We start off every group working together to decide like what area of our body is feeling most tight, most stressed, and so we're working together as a group to share in a self-care practice. And the drop-in center gave me the freedom to bring something that was really, really helpful for me and pass that along to the people that we work with, which is, it's incredibly rewarding to be able to do that.
Thank you. Other questions?
How do you think you can promote this to get more people that have the lived experience to know this is a pathway forward to their own recovery journey, to help others? Because it is so new, I don't think a lot of people even realize that the special power that they have, that they can help others.
Yes.
I work for Blue Cross, but I'm a licensed LCPC. I've managed peers internally at Blue Cross alongside clinical staff and love that model. And I love the work we're doing. I'm also on board at NAMI too, so.
Oh, great.
Nice to meet you, I'm Suzanne. So I'm a big proponent of peers and how we can, especially in our rural communities, so I cover all of Illinois, and so looking at the behavioral health workforce shortage, but there's a large need for peers, and it's an opportunity for those individuals in those counties to really fill that shortage, but also give themselves a workforce employment pipeline, right? So they just don't know about it, like a lot of people. So how do we get the word out to people to understand they have this special power, they can get trained, they get a certification and a pathway towards employment?
I wish I had an answer to that. I really do.
Right.
What we're doing right now is it's all grassroots, so it's going where people are and explaining it to them. So there's nobody in my circle of acquaintances who doesn't know about this. I just make it a personal thing. As far as marketing, I mean, you're absolutely right. Not only is it an unknown, I like the superpower idea too. Is that people don't know they have this power and it's available, they can use it. Taking it a step further, the NAMI Drop-In Center has been on that street for 30 years. We still get people coming in that didn't even know it was there. People that live in Oak Park. So it's one of the greatest challenges that we face. And I'm going to throw it back to the group. How can we get the word out better about this? How can we let more people know about the group? I like it. Yes.
Well, I wanted to uplift
Yeah.
the work that Thrive does and having when you do the community outreach and to have a peer recovered person with you at all times.
Right.
And as many digital and other telecommunications tools we have at our fingertips, still nothing really beats word of mouth.
Yeah.
And when you have that initial touch of building the trust with people that you're reaching out to in the street, they're talking to each other. The Oak Park Homelessness Coalition had a presentation in July, I want to say, about food access among unhoused populations in Illinois, and the number of people who are providing dietary support to each other. Knowing, oh, this person's diabetic, they can't have that thing that somebody just handed them, and knowing how well word of mouth goes through, and just simply keeping their peers. We see peer support informally and formally, but that word of mouth, that constant, like when you're out in the community, making sure that you have, you're constantly telling people about it and proving that you have those things. Because, hey, this service exists is not, until you see that service in action, you're not going to believe that service exists.
Or trusted.
Or trusted. And so simply just drumbeating the word of mouth, and drumbeating, for those of us that aren't necessarily in peer support, we don't have the qualifications of having been in a psychiatric hospital. Letting our communities know that these services exist, and and so when somebody says, oh, I really want to support somebody who does this, did you know that these things exist for these particular purposes? Because you guys need a salary too.
Yeah, thank you.
Just a couple ideas for how to get the word out, which you might already do, because I think I heard about this talk because I was posted on Mom Mail.
Oh,
So
okay.
just Mom Mail is such a great, local listserv for posting anything, events that are happening, or even just businesses and organizations and what they're doing, and just to let people know. So I think that's a great way to get the word out. And then we probably already do a table at Day in Our Village, but specifically have a sign that talks about peer mentoring or something, so that they know, do you know about peer mentoring? Something like a question, do you know about peer mentoring? And then someone say what is that?
Those are great ideas.
And then the library, just the post, the wall to post things, that also is just a good place where there's a lot of traffic for people to see look at what community activities there are going on.
Wonderful, thank you.
Yeah, and I also just want to say I really like the work that you mentioned. What's it called? Meat Corners lot. So I'm a middle school teacher, and we had a crisis this year at my school with a student taking her life. And the lots came over to the school, it's provided like so much support for staff and students, and it's great.
Thank you for sharing that. Yes, sir.
Well, I know that one of the things that Ami does in terms of getting the word out is the education programs in middle schools
Yeah.
and high schools. Maybe you just say.
I can speak to that a little bit. Sure, yeah. There's a couple of programs that NAMI is, and I'm sure about Thrive, if Thrive does any of the education programs or not. But we speak, there's something called Embracing This, or Ending the Silence, which is somebody with a lived experience of mental illness speaking in the middle schools and in the high schools, telling their story to students, and demystifying and destigmatizing mental illness so that they feel more open to talk about it. Yeah, it's one of my favorite programs because we've done tens of thousands of students we've been able to speak to every year.
Thousands and thousands of kids are exposed to
It's really remarkable.
stress and management.
One of my biggest takeaways from that is how many kids feel very, especially younger kids, feel very free asking questions. It's kind of refreshing to see somebody who's in 6th grade just ask a very intelligent question about depression. Wow, that's amazing. Kids are in tune. There was nothing like this when I was in school. Nothing even close. Definitely would change my life if I had explored those things when I was younger. Thank you for bringing that up. It's really nice.
I come here more like as a parent, so I wonder, one question is, do you work with social workers at the high school so they can recommend one of those programs and encourage the teenager to participate? And the other part is like, how parents are actually, I'm in this role, I'm a stepmom, how can I encourage the teenager to participate in the peer support when they're already being hospitalized and they might look at it as that's another medical intervention, how to build that bridge so they're open.
My recommendation is take them to the loft.
Yeah.
Take them to the loft. As a parent, I would definitely say that. And the previous question was about, if you remind me.
How's your work with the social workers and how can they help with that?
Yeah. I don't know personally whether we have a relationship with the social workers. I know that it's probably 24 schools in this general vicinity that we have relationships with. I don't know if they're directly with social workers or with administration. But definitely social workers in these schools are armed with materials, not just from us, but from Thrive as well, so that this information is available to them.
I can speak to that a little bit as well. So, crisis, especially like the on-hours crisis shift, a lot of the time we're either going out to, we've been to the elementary schools, middle schools, high schools, Trinity, we've done QPR there. I don't think we've had crisis there, but we've had students that we're actually going out to at the schools or they're being sent to us. And it's usually the parents and then the school social workers that we are communicating with, but I do think we can all collaborate on more upstream ways because one of the biggest things is, again, reducing the stigma, especially when it comes to suicide. That's a really, really difficult topic to kind of have that conversation with kids. One of the resources I would suggest is Robbie's Hope is a foundation that was started by a woman who lost her son to suicide. And what was really, really cool, similar to like our Mental Health Matters book that Amanda put together for us, what the community did is they got the teens together and the teens wrote a guide to help the parents have these conversations. So how to have the conversation with their kids, when to have the conversation with their kids, and just make it to help facilitate that dialogue. So the Robbie's Hope handbook is something that I like to provide to parents a lot of the time if we're seeing a kid and there's mental health concerns, especially when it comes to suicide. There's a podcast that I'm forgetting the name. It's called Hopeful Conversations. That is something I like to typically recommend to parents. That when we started doing QPR, the handbook was something I started reading, and then just listening to that podcast really helped me get a better understanding of like the enormity of the teen mental health crisis, and then how to support them from the perspective of the kiddos. I thought that was really, really cool, that they were the one talking about, this is what we need, this is how we want you to approach us.
Just to sort of piggyback on that, there's a collaboration of local providers, including Thrive and NAMI and Community Mental Health Board and others, who work with the folks at the high school to put on a couple times a year Parent University.
Yes.
So what we do is we bring in